Thanks very much, Kamlesh. I think that set the scene beautifully for primary care management of type 2 diabetes. And we'll follow on with Simon Griffin. Simon's role is Professor of General Practice at the University of Cambridge. And I've picked out three other areas of activity. Firstly, he is Assistant Director of the Medical Research Council Epidemiology Unit, based at Cambridge. He's Deputy Director of the UK Clinical Research Collaboration Public Health Centre of Excellence for Diet and Research and Activity Research. Thirdly, he is the Primary Care Lead for the Eastern Region Diabetes Research Network. So, like Kamlesh, extremely well qualified to address the topic of promoting behaviour change among people with type 2 diabetes. So please welcome Professor Simon Griffin.
Thank you very much. So thank you very much for inviting me. I've got a slide in a minute that underlines why I'm very pleased to be here. But I often start off at these meetings with my primary care colleagues to point out the words of James Mackenzie. I hesitate to do this in front of the medical dean. But essentially what James Mackenzie said was that if you want to advance medicine, given that most medicine happens in the community, we need to have research going on in the community. And hopefully the audience here will be sympathetic to that view. So I'm charged with showing a picture of your medical school in the background and talking about behaviour change. So what I thought I'd do is follow on from what Kamlesh says and describe what we can add to very good general practice care, which is, I think, where he ended up. So I'm a GP in Lensfield Road in Cambridge 1 day a week. That's a Victorian premises in which we practice. That's my old car. You can just about make out the dents where the patients reverse into this area where they're not allowed to park and then leave quickly. And that's what a GP looks like in Cambridge, sitting at the desk. If you're ill in Cambridge on a Thursday, then I'd choose somewhere else because you might have the misfortune of seeing me. That's where I work the rest of the time. This is the Addenbrooke's Biomedical Campus. This is a very old picture now because this is where I work for some of my time. This car park is now a building. This is going to be the largest biomedical campus in Europe in 2020. That's the new building that I mentioned with the diabetes clinic at the bottom and the MRC unit on the first floor, and then people doing molecular work on leptin and obesity and FTO and things like that on the floor above us. It's interesting that the people who work on this floor who are interested in diet and physical activity are all quite slim and climb the stairs. And the people who are convinced that this is a genetic problem take the lift. And they're a little bit larger, but I shouldn't perhaps say any more. So when I'm not doing those things, this is what I like to do. And this is just to prove that there are waves in the United Kingdom. Not many. This is in the North Sea, and that's Cromer Pier there. This sea gets down to about 4 degrees in February. So this wasn't February, so I got no boots or gloves on. But because there aren't many waves close to Cambridge, I have to have this alternative pastime which annoys the punters, but keeps the tourists amused. I must be on about an hour's or millions of hours worth of Chinese tourist video cameras. So if we want to do something about the burden of diabetes, we could focus all our efforts on treating people with the condition, or perhaps we could find people earlier, or perhaps we could have policies that try and shift the population distribution of glucose. And I think all are important. What you'll find today and what you'll find at the IDF meeting is that most of the conversations are here, most of the evidence is here, and there's much less here. Another way of putting that is, this is what we're talking about mainly today, prevention of complications, treatment of people with the condition. But earlier detection and even primary prevention are as, or if not more important. And obviously that has to happen in primary care. There's nowhere else that it's going to happen because our secondary care colleagues don't see these people. So it's interesting how that slide you chose, which is fairly recent, this slide is from, I think, the 70s. And the clever specialists used to look after diseases like hypertension, asthma and diabetes. And they used to look down on their GP colleagues who spent most of the time on the golf course. And actually that bridge narrowed quite a lot in the 80s and 90s. But I think Camish is absolutely right that it's actually got wider again recently. And many hospital specialists are feeling very threatened by the changes and having their funding taken away and given to what are called clinical commissioning groups. So that was the position then, and as Camish showed you this slide earlier, that in the trials of comparing GP care versus hospital care, that is, patients were randomised to stay in outpatients or be discharged to GP care. If the GP care was haphazard, then patients did worse. If the GP care was organised with a register, a recall system and regular review, then patients did as well or better in primary care. And if you look at these other outcomes, the same is true. If GP care was haphazard, then patients did a lot worse. If GPs had a register, recall system and regular review, then they did as well or better, and tended to be at lower cost and with less losses to follow up. Patients like to come and see GPs even if the care is less good. They can park more easily, for example. So actually GP care and chronic disease care was well described by Julian Tudor Hart, who was a famous socialist GP in South Wales. He coined the inverse care law. The people with the most resources get the most care, the people with the most need get the least. But he also coined this phrase: good management of chronic disease involves doing simple things well for large numbers of people, few of whom feel ill. And the register, the recall system and regular review drives that. If you've got someone on the list and you know you should see them once a year, you're more likely to. If they're in front of you and you see them, you're more likely to take their shoes and socks off and look at their feet than if they're not there. So this is the basis of good chronic disease management. But then that was added to by people like Niels Define Oliverius, who's a Danish researcher. I have a funny story to tell. Well, I think it's funny. A funny story to tell about Niels Define Oliverius. We were in Vancouver at a meeting of NAPCRAG, North American Primary Care Research Group, and we were introducing ourselves. It was a diabetes special interest breakfast meeting at about 6:30 or some ridiculous hour. And we were going around, and we all had to introduce ourselves. And he said, hello, I'm Niels Define Oliverius, and many, many thousands or hundreds of years ago, my ancestors came and found this country. And then it went round, and there was a Native American there from the Huron tribe who said, many, many hundreds of years ago, my relatives were here and welcomed your relatives when they came to find our country, which may have some relevance in this country as well. So what he added was that once you have a good system, register, recall, regular review, if you then have prompting of doctors, clinical guidelines, feedback, and continuing medical education, you can actually get outcomes as good as the intensive treatment arm of the UK PDS. But more than that, when the 6-year trial stopped and he had the 18-year follow-up, he found that 6 years of that intervention led to significant reductions in diabetes endpoints and heart attacks. So if you want to add to the register, recall system and regular review, then those would be the things to do. We then did a Cochrane review to follow up that first Cochrane review that I showed you. Carrie Renders led this from the Netherlands. And it looked like that the things that you could add from the trials were suggesting was patient education, the enhancement of the role of the nurses in diabetes care, and I know that's very topical here where practice nurses are much less common than in the UK. In the UK, the practice nurse is the linchpin of diabetes care. Many GPs are becoming de-skilled in diabetes care because one GP in the practice does it and all the rest have forgotten what to do. And it's the nurse that provides the continuity. So those will be the things to add. So following up from that last review, in looking at the literature, I think these are the things that define good diabetes care in European countries such as the United Kingdom. So guidelines, planned patient reviews focused on outcomes-related processes. So things where there's good evidence between the process measure and the outcome, focus on measuring the process. Annual seminars, audit, feedback. A charismatic opinion leader. Every shared care system that's worked well has had a charismatic opinion leader from secondary care, such as the person in the front row, and a charismatic opinion leader from primary care, such as another person in the front row. And actually those things are quite difficult to define and measure, but they're consistently present in all successful shared care schemes. enhancement of the role of the nurse and other non-doctor team members, and clinical information systems. And I think this is where we've made a great progress and where there's perhaps opportunities in Australia. So this is a clinical information system developed by a GP in Norfolk and used in many PCTs. And what this means is if you sit in a management office, you can look at the data from all the practices and you can rank them according to how they're doing against all these key indicators that we know are strongly related to health outcomes. So if you wanted to encourage a practice, you might be looking down at the bottom of this league table. But you can also look within a practice at individual patients. This idea that we need to see everyone once a year is a relic of a sort of outpatients. What we need to be doing is this person seeing much more often with their HbA1c flux changing here, for example, going up by 0.7 since their last measure. And then the person down the bottom of this list ordered by HbA1c in this case, but it could be cardiovascular risk, you might need to see a little less often. Then you can look at your data for your whole practice. We can see how many patients are in these different HbA1c categories. If you click on this, they then all come up in a list. You can then focus on an individual patient. You can see that HbA1c over time, and you can see that it suddenly shot up. And if you go on to the next page, you can see the reason why. This is individualized feedback for the patient, and what happened is they were admitted to a residential home or were being given cakes most afternoons. So the individualized advice here is no more cakes, inspect on special occasions. And the patient knows, or in this case the residential home carer knows, all of the drugs, what they're for, etc. So this is the power of IT, and I think for chronic disease management it has a really important role for individual patients, for practices, and for clinical commissioning groups buying care for patients. So going back to the second half of my list, so prompting and reminders of patient view and the contents of patient reviews. If you're sitting in a surgery consultation room and the patient comes in and it flashes up on the screen, measure the patient's blood pressure, because if you don't, your earnings will be reduced. Which effectively is what it's doing for the quality and outcomes framework that Cam described. Then you are more likely to do it. So additional decision support for practitioners. So not only measure it, but if it's above a certain level, consider this drug or this drug, etc. So many of you will probably use systems where if you prescribe a drug that interacts with one they're already on, it tells you. Setting of realistic treatment goals. Diabetes is an inexorably progressive condition. It doesn't help to continue blaming yourself or the patient for the fact that the glucose rises over time. It will rise over time. We can't provide good care unless we have good access to specialist advice. Kamesh showed the Super 6 from Portsmouth. There are many other models. But if we undermine the specialists by removing all their resources, then patient care is going to suffer in the longer term. Patient education and support and educational materials for patients. Although the education, if you look at most of the trials, and indeed Kamlesh has done one of the foremost, the Desmond trial, the outcomes that are better at 1 year are often fading or similar in the two groups by 3 years. So one-off education when people are diagnosed is good, but ongoing education would be better. So we wondered what we could add to that. So if we had good organised care in general practice, what could we add to that to improve it? And in the 90s, what was very topical was patient-centeredness. So it was thought, particularly by Americans like Greenfield and Kaplan, that if you listen to the patient more, let them speak more, then their behaviours will change, their diet will be better, their physical activity will be better, and their outcomes will be better. So we wanted to test this in a randomised controlled trial. And so I drove around Wessex in the south of England. Portsmouth, that Candice was mentioning, is just there. I used to live on the Isle of Wight here, and I used to go to work by boat in those days. So I drove around Wessex recruiting these practices. And we randomised these practices to intervention or comparison. Every newly diagnosed patient was registered by the practice into this trial. And the intervention practices got training in patient-centred care, particularly the nurse in listening more, eliciting the patient concerns, etc. And the patients got a booklet that had a section where they'd write their issues that they wanted to discuss, then a separate bit where the doctor would write his or her issues. And we had icons all around this booklet about what were the sort of things that patients might want to discuss. We had an interesting meeting trying to work out what the icon should be for erectile dysfunction, but I won't labour that point today. So all the patients got standard materials for people newly diagnosed with diabetes, and then we followed the patients up at 1 year. So what effect did we have? Well, patients preferred this mode of care. Their well-being was significantly better in the intervention arm, but they were also heavier, and their blood pressure, while not statistically significant, looked like it was higher. These two obviously related. It may be patients were taking their sulfonylureas better, and that's why their HbA1c might have been slightly higher, or again not significant, and why their weight might have been higher, but we never measured adherence. So this was disappointing. We couldn't replicate what was happening in California in UK general practice. So we paused at that point. And we undertook a review that Diabetes UK gave us £3,000, 3,000 British pounds for. And this was to do a systematic review of all educational and psychosocial interventions for people with diabetes. And what we found was that it was a hodgepodge of not very good research. Most of the studies had very poorly defined interventions. You couldn't actually say what was going on. Few of them were based explicitly on theory, educational theory or psychological theory. Where they were, outcomes tended to be better. The outcome measures and the process measures were poor. Most of them relied on self-report measures of behaviour. And the thing I've learned is this, that if you sit with someone and you suggest to them that they should eat less and move about more, and then a few weeks later you give them a questionnaire that asks them if they're eating less and moving about more, even if they aren't, they will tend to write down that they are. So you can still get trials published in the BMJ and other good magazines that have self-report behavioural outcomes. But I would be very suspicious about how valid they are. So this was around the time that the MRC was developing its framework for the development and evaluation of complex interventions. And so we were keen to identify what the key behavioural determinants were that underlined the behaviour, such that when we intervened, we could target these. Then if the diet and physical activity did change, it might influence these and then subsequently these. And the behaviour we started with was medication adherence, because like it or not, the tablets do work. This is the UK PDS data. And in order to get good control of blood pressure and then the beneficial outcomes as a result, patients need to be on several drugs. We undertook a randomized trial called Addition, comparing intensive treatment versus standard care for screen-detected patients. And because of things like QOF, we only managed to get relatively small differences between groups in their treatment of blood pressure lowering, lipid lowering, and glucose lowering. That was at 1 year. At 5 years, the differences were even smaller. But in spite of those differences being small, in Cambridge, we managed to achieve a 42% reduction in mortality over 5 years. So those small differences in drug treatment do work. So the problem is that people don't take their tablets. If you define medication adherence by taking more than 90% of days having adequate coverage, defined by script encashment, whether you pick up the prescription, then only less than a third of patients taking one drug take them, according to that. And only 13% taking two drugs, metformin and sulfonylurea, actually adhere. So medication adherence is a major problem. So with colleagues in Oxford, this is the SAM study, Supporting Adherence to Medication. We developed a behavioural intervention drawing on the MRC framework. The behavioural intervention drew on the theory of planned behaviour, targeting people's attitudes and beliefs about intentional and non-intentional forgetting. And then it had an implementation intention element, which is aimed to move from your intention to an action. So you write down that on Thursday night, I will put my tablets by the toothbrush, and then from then on, every night, I'll remember to take my tablets. And you actually write down this implementation intention. So we, again, tried to improve on previous behavioural research by measuring the behaviour objectively. And we use a MEMS container here, which has a microchip in the lid. Every time you take it off, it produces a little dot on this printout. So it looks like this person is actually taking their medication relatively well. Of course, you could say they may be taking it off and then tipping it down the toilet. So we don't know that they've actually swallowed it. But it's difficult to imagine that many people would go to those lengths to deceive us, although I may be wrong. So what did we find? Well, this was more promising. We found that this theory-based behavioural intervention led to 8.4% better adherence, with adherence being defined on the percentage of days the correct dose was taken. So we were cock-a-hoop. We thought, marvellous. Unfortunately, most of the journals didn't seem to agree with us, so we ended up getting published in BMC Family Practice rather than the Lancet or the BMJ. And now in medication adherence, things have really moved on. And again, this is where technology really can help. And one of the things that we're focusing on now is the fact that in the not too distant future, I would predict that all tablets will have a tiny microchip in them, such that when you swallow it and your stomach acid reacts with this tiny bit of metal on this silicon chip on the tablet, it can send an impulse to a device that you wear. And if you go onto Proteus Healthcare, their website, you will see this device. So you wear this all day. It measures your physical activity, your body temperature, whether you've fallen over or standing up, whether you've taken your tablet or not. And it Bluetooths to your phone, to your iPad, to your Apple PC. And then your relatives can see whether you've done this. And they can text you to tell you to take your tablet. Or your specialist in hospital can text you because they can see that you haven't taken your tablet over several days. And this is the direction of travel for the management of chronic disease in developed IT, well-resourced countries. And this is one of the areas that we're hoping to pursue in one of our next trials. So what about other behaviours? Well, in that addition trial that I mentioned to you, an observational analysis showed that if you didn't change any behaviours, you had a far higher risk of having a cardiovascular endpoint over 5 years. If you met 4 behaviour change scores, i.e. you reduced your alcohol, you reduced your fat, you increased your fibre, you increased your fruit and veg, and you increased your physical activity, then you are much less likely to have a cardiovascular event. So the observational data are very powerful. The problem is translating the observations into actions. So we decided to review, again, the evidence, the theory and evidence relating to 4 health behaviours: healthy eating, physical activity, taking your tablets, and stopping smoking. So rather than focusing on 1 behaviour, we're now focusing on 4. We undertook consultations and focus groups with people with diabetes, and we undertook pilot work. And we aim to test the efficacy of this theory-based behavioural intervention over and above intensive best practice general practice care. We aim to use objective health behaviour measures, and we also measured cardiovascular risk factors. And we did this among people with recently diagnosed diabetes, so some screen detected and others diagnosed in general practice. So this was the intensive treatment that all of them were getting. So we funded this as part of the addition trial. Encouraging GPs to prescribe more, encouraging nurses to educate the patients using this theory, Leventhal's theory about illness beliefs, and giving everyone a theory-based educational materials. So that's what they all got. And then what we added was trained facilitators, so practice nurse, dietitian, one was a social worker. They were trained by psychologists to deliver our theory-based behavioural intervention, which consisted of 7 sessions, so 1 a month for the first 6 months, followed by phone calls. And it was targeting, as I say, these 4 health behaviours. Patients could choose which one they wanted to focus on first. So this was our model. We hoped that by changing people's illness and treatment representations, we might also change their attitudes, their subjective norms, their perceived behavioural control. This is a theory of planned behaviour. We hope that would change their intentions, that would change their behaviour, that they'd form habits, that would improve their physiology and biochemistry, reduce their cardiovascular risk, and then we could model ahead at the end of the trial through to morbidity and mortality. We hope that this would also improve their well-being. And we had measures at each stage of this causal model. And I'm grateful to John for modelling the physical activity measure that we used here. You don't actually need to wear 2, one's enough. This is called an ActiHeart, which has an accelerometer and a heart rate monitor. So everybody at the end of 1 year was measured for 7 days using one of these to measure their physical activity, because of the issue I said to you earlier about if you tell people to move about a lot, then give them a questionnaire, the chances are they'll tell you they are moving about a lot. For the other behaviours, we measured fruit and vegetable consumption with plasma vitamin C. We measured smoking with self-report and plasma cotinine. And we measured the plasma level of metformin in the blood. Well, the plasma level in the plasma. So this was the design. patients were randomized to no behavioral support or behavioral support, and we managed to remeasure well over 90% of people at follow-up 1 year later. What did we find? Well, this is the baseline. So patients, as you can imagine, were overweight. HbA1c was not too bad. They're early on in the disease trajectory. Cholesterol was fairly good. Remember, they're being intensively treated. Most of these people are already on statins, already on ACE inhibitors, etc. And relatively small proportion were smoking, but were watching a lot of television. So what did we find at 1 year? Well, we found no difference in any of our objectively measured health behaviours at 1 year. We also found no difference in any of the biochemistry anthropometry measures at 1 year. So the confidence intervals for all of these outcomes cross no difference. However, the patients felt better. Their questionnaire, their SF-36, actually was significantly improved in the intensive treatment, in the behavioural support arm. And while initially we thought, well, they've been having a nice facilitator, which was usually a woman, sitting with them for an hour at a time, listening to them, who wouldn't feel better? But actually, this SF-36 outcome is probably not unimportant, because if you ask me what will be a better predictor of early mortality, cholesterol or SF-36, SF-36 wins every time. So how do we interpret this? Well, if you're getting really good care in general practice with all that theory-based standard advice, it's difficult to get improvements on that with even a very intensive approach, which our NHS couldn't probably afford, and I suspect your health service couldn't either. A facilitator seeing someone for an hour a month for the first 6 months and then telephone follow-up after that. As I mentioned, we think that sitting with a facilitator improves people's view on their health. The importance of that, it's difficult to interpret. We think that at the moment there's no evidence to justify this additional resource of this behaviour change specialist. And the other thing we think about now, and the painful lesson that we've learnt, and the painful lesson I want to share with you, is that relying entirely on psychological theory is a problem. I hope if there are psychologists in the audience, please forgive me for my 2-minute summary of the history of psychology. And you can please ask questions at the end and challenge me. But I think what I thought we'd learnt from psychology is that we really needed to target attitudes and beliefs if we wanted to change behaviour, because they were very strongly associated with behaviour and behaviour change. What I've since learned is that a lot of psychology started out with American college students, was largely based on cross-sectional studies, and didn't measure the behaviour objectively. In all our studies, where we try and evaluate an association between attitudes and beliefs and objectively measure behaviour, there is no correlation. Similarly, when we try and study the association between attitudes and beliefs and change in behaviour, there is no correlation. So I think having theory is better than having no theory, and going back to the old days when doctors used to tell people what to do, and they largely didn't follow that advice. But I think slavishly following the theory may be not required, and I'm going to give you some alternatives to that in a minute. And the reason that I feel empowered to say this is because the father of American psychology made this observation, and that is that most of the behaviours we're talking about, diet and physical activity, are habitual. And we don't actually think about them. We don't go through this cost-benefit analysis like some kind of health economic model deciding should we or shouldn't we eat that Mars bar. So, for example, many of us climbed the stairs rather than took the lift. That's because everyone else was climbing the stairs. If it had been impossible for me to find the stairs because people hadn't shown me, I may well have got the lift. Similarly, at lunch, I ate lots of fruit because there was a big plate of fruit the moment I arrived. If there'd been a big plate of cake the moment I arrived, I would have probably eaten the cake. Similarly, when I arrived at Melbourne Airport, I'd been sedentary for 24 hours. So I got off, and the first thing I did was stand on it. Well, I didn't actually, but the first thing most people did was go on this travelator to help them walk the 100 metres to the customs point. Okay. So the behaviours we're trying to change here, diet and physical activity, are habitual. The behaviour that I mentioned earlier where we had more success, tablet taking, and then things like condom use are slightly less habitual, and maybe there's more of a cost-benefit analysis going on, and maybe they're the things where the psychological theory has greater utility. The things that affect our diet and our physical activity are actually much broader than this. And Australia is in the lead. In fact, universities here, particularly in Melbourne, are really making great strides with understanding the wider determinants of things like our diet and our physical activity. The studies, unfortunately, are fairly limited, and doing trials in this area is difficult. Where there have been lots of trials is in things like signage, because you can do that quite easily. Make a sign, point people to the lifts, and then count how many go to the lifts. Doing a randomized controlled trial of your town design is not possible. And so you rely on much weaker evidence like natural experiments. But increasingly those are happening. So for example, if you're like Camlish and you live in this gated community here, you have to drive to get to the shopping mall here. And that puts you at real risk of the consequences of sedentary behaviour. If, like me, you live in a mixed urban retail environment, educational environment, where you have a shop next to an office, next to a residence, then you're more likely to walk to your accommodation. So European cities like Brussels and Amsterdam are more like this. American cities are more like this. And I fear that Australia is following more the American model than the European model, which I think is a concern. We're doing a lot more TV viewing, and it seemed to spike in around the 80s. Now, this may be the Sullivans or Neighbours. In the UK, I think it's Starsky and Hutch, or possibly the Ewings. And the challenge is that in primary care, we're being given the responsibility to reverse evolution, and I think this is unreasonable. I think that if we're going to make a difference in our focus with patients with diabetes, then the context needs to be different. I think that our behavioural interventions would have been likely to be more effective if the choices were easier and if the defaults were easier. Now, there is some positive news, and I said I was going to give you an example of what to do if not slavishly following psychological theory, and that is the behaviour change techniques, which do, of course, still come from the discipline of psychology. So in our Addition Plus trial that I described to you earlier, the behavioural change techniques such as goal setting, action planning, use of prompts, reminders, motivating oneself, getting social support, self-monitoring, goal review, and preparing for setbacks. So those techniques were used at varying levels. And what we found is the change in BMI from the beginning to the end of the study directly correlated with the amount of those behavioural change techniques that the patients were using. And in particular, the goal setting, the reviewing goals, and the social support. For some reason, self-monitoring wasn't, which would have been the one that I would have said was most likely to. Virtually every weight loss program that's successful has self-monitoring of weight and then offering self-monitoring of physical activity and diet as well. In our study, it wasn't. And of course, self-monitoring, again, going back to IT, is becoming increasingly ubiquitous. So all of you looking at your phones now, your phone contains almost certainly an accelerometer and possibly a GPS device, so that it's possible for you to monitor your activity on a daily basis. And given the nature of the challenge that I just described to you earlier, these individual-based approaches that we have in primary care of seeing someone in front of us are quite expensive and are not really scalable up to the large population and this epidemic that we've just been hearing about. So the fact that this is scalable makes it more encouraging. And again, one of our focus now is changing to this sort of self-monitoring and intensive self-monitoring of behaviours, and this is where we're putting our investment in terms of behaviour change interventions and trials. So the challenge that Kamish described was here, above the diagnosis of diabetes. But I would suggest to you that the challenge and the tidal wave, and indeed this looks rather like a tidal wave, lies here. So if you're in rural Cameroon, then you're in the solid line. If you're in urban Cameroon, you're in the dotted line. Similarly, if you're a Jamaican in Jamaica, this line. If you're a Jamaican in Manchester, this line. So the whole population distribution of glucose is changing. And if all we do is focus on the small number who've tipped above this somewhat arbitrary threshold, then we're missing a major point here, because this steep line is getting closer and closer. But more than that, your risk of a heart attack is approximately linear here. So in order to reduce the complications of diabetes or the complications of glycemia, we actually need to shift this whole distribution back this way. So this is the slide I showed you at the beginning, and that's why I'm returning to it now. Much of what you've been hearing today has been about treatment of people with the condition. But I would argue that in primary care, we're ideally placed to make a contribution much further up the disease etiology pathway. And actually, we should be like Julian Tudor Hart, that GP that I showed you, who was responsible, almost like a public health physician, for his 1,800 patients in that Welsh mining village. Where can we find out what works? Well, I think that smoking gives us a good example. So this is a similar slide to the one I just showed you, but this is for smoking and not diabetes. And similarly, you have patients who need treatment from their doctor, although these days you can buy this, you don't necessarily need to be prescribed. But in primary care, we might need to screen people and do brief interventions, but we also need things up this end. And actually in Australia, you're way ahead of most of the countries in the world for public health taking a, what I would regard as responsible attitude to the current epidemics. Nobody would put up with a government that didn't do something about epidemics of communicable disease. But many governments seem to be very happy with not doing anything about non-communicable disease and worried about the nanny state. And this is what's happening in the UK, where we don't have plain packaging on tobacco, for example, and we don't have a minimum unit price for alcohol, despite the evidence. So I think you here in Melbourne are actually leading the way in some of these more wider public health approaches. One good example from the UK was the ban on smoking in public places. And the reason I choose this is because most people thought that this would be good, but they thought that it might take 20 years before it produced an effect. And yet, actually, these dramatic effects were seen within months. So many of these other wider population-based approaches, I say to you, why don't we do them? What harm do you think we're going to cause? And the one that I particularly pick on is taxing sugar-sweetened beverages. So the good thing about taxing sugar-sweetened beverages, unlike taxing fat, if you tax fat, people might eat more sugar. So there's a real issue of substitution. If you tax sugar-sweetened beverages, the chances are people will drink more water or drink more fruit juice. So the harms are likely to be much less. Now, there'll be harms for Coca-Cola and other companies, and there'll be harms for government ministers who have shares in Coca-Cola. But overall, for the population, I think that it would be beneficial. So I'm going to stop there and just conclude with these remarks. So primary care teams, as Kamlesh and I have tried to suggest to you, have really important roles in reducing the burden of diabetes. We focused on treating people with the condition, but I've tried to also introduce the idea of finding people who've got the condition but don't know it yet, and then also preventing people getting the condition in the first place. And I think primary care teams are best placed to do that in the health system. I've tried to describe the characteristics of good diabetes care, and I think they've been pretty well specified now. I think the challenge in Australia relates to the single-handed doctors, relates to the nature of payments for specialists and GPs, and relates to the numbers of practice nurses available to take on much of this routine diabetes care, which they tend to do better than GPs. Knowledge, attitudes and beliefs may be necessary, but unfortunately they're rarely sufficient to initiate and maintain change in health behaviours. I think we need greater focus on the behavioural techniques such as goal setting, action planning, preparing for setbacks and self-monitoring. And I think we have some of the tools available to help us with that now. But I also think that the responsibility for the diabetes and obesity epidemic is not the fault of primary care teams. We're part of the solution, but I don't think we're the only solution. And I think there are wider collective approaches that need to be put into place. So thank you for your attention, and I'm happy to take questions.
Look, I think rather than start a discussion that we'd have to truncate, I'll just thank Simon and Kumlash on your behalf for really very inspiring and also scholarly presentations that showed us the benefit of research in influencing practice. And we'll quiz both of you during the panel discussion. And the psychologists can think of their questions in particular. So thank you again.